big thank you to the local hosts for the opportunity to share my work here. I'll be talking about some biomarkers that have been developed using exposome technology. But before I go any further, I want to declare my conflicts of interest. As I was introduced, I'm a CEO of academic spinout, and all my conflicts of interest are managed by Mount Sinai in accordance with institutional policy. Yesterday, when Dr. Balshaw was speaking, he mentioned one of our colleagues, Dr. Stephen Rappaport, who's made significant contribution to the exposome field, and these graphs are generated from one of his studies. Using heritability as a crude estimate of genes and environmental contribution to disease, he showed that the environment, the exposome, makes a very significant contribution to chronic disease. And that's nothing new for this audience. But keeping this in context, then it falls upon us as the leaders of exposome science how to make the exposome impactful. When Dr. Robert Wright was speaking yesterday, he talked about environment as medicine, or the exposome as medicine, and how incorporating that in precision medicine could have payoffs for both prevention and discovering new treatments. And so many have spoken here, and there will be a panel discussion on the global efforts in Europe, in US, in Japan, and that will hopefully translate to policy. But I feel that there is another avenue, and perhaps an avenue where we could be impactful much faster. And that avenue, for me at least, is to empower people to improve their own exposome. We've heard many times this phrase that is said so often, but I don't think we are fully capitalizing on it. And that phrase is, you can't change your genes, but you can change your environment. So let's empower people so that they can change their environment for the better and then improve their well-being and their health. Let's dig a little bit deeper. Of all the environmental exposures, how many does the average person, I'm not talking about this audience, because when it comes to exposome science, you're not the typical person. Most people on the street don't even know the name yet. But how many environmental exposures are people measuring? What are they monitoring in their house routinely? And you start really thinking about it, it's very few, Maybe there's a thermostat, although the one in my hotel room doesn't seem to be doing anything. I still wake up hot and sweaty, and I'm alone, so what's going on? And then there is a fire alarm, which is not really monitoring anything, because if that goes off, it wasn't that it's monitoring something regularly, something really bad has happened, right? So that's not monitoring. And maybe your Apple Watch is measuring a noise pollution, or it's measuring some crude measure of air pollution, but it's not really measuring the health of your house. That's one area that I want to be impactful. I believe we all can, and in fact, it falls upon us to actually do it, because people need that. Take a moment to look at all these disorders. They might seem like they're from different domains, and the topic of this symposium is brain health. So, what is common amongst them? For me, a stark reality of all of this, both as a scientist but also a parent of a neurodiverse child, is that none of them have really good biomarkers or biochemical tests for early detection. How do we diagnose autism? It's on a questionnaire. How do we know someone's a schizophrenic? Well, they have an episode of schizophrenia. They behave like it. So by the time the behavior presents itself, it's very late. We diagnose ADHD around the age of 7, 8, or older. Autism is diagnosed in the US at the age of 4 or 5. It's even later in France. In Sweden, it's about 7. Same thing in Japan. It's much later. For a condition that has a big heritability component, for a condition where therapy works, if you detect it in early life, we find it so late. Genomics has tried. Genomics has put a lot of effort in some of these disorders, like autism. It hasn't delivered. So it falls upon us to bring about that change. And this is where my team has been working. As academics, we do research, but the taxpayer who's funding our lifestyle is waiting for a solution. Here is something, and go have that change. Again, I'll share my experience as a parent. They scan my daughter for every kind of genomic test, and of course they find a microdeletion. They said, for this microdeletion, We've seen kids who pass away in their teenage years, but we also have a Harvard professor, someone who plays for the Philharmonic, the orchestra. So you can be highly successful or you could die in a few years. There's your answer, Wonderful, we've solved all your problems. So you go home not knowing what to do next and feeling like, hey, I have 2 doctors in front of my name. If this is my experience, what the hell's going on? So she was misdiagnosed with autism, and I'll share the journey of why I partly started down this line. I want to share with you a technology. And this technology was built in response to one of the biggest challenges of the exposome. The exposome is dynamic, right? Your genes are pretty much set at conception, some epigenetic changes, but for the most part, I could do a genomic scan today versus when I was conceived, born, and it would be about the same. The challenge here is the exposome is dynamic. How do I measure it at repeated intervals? I'm not talking about prospective cohort studies where you come once a year and you do a snapshot test. I want fine scale dynamics. So let's say every hour, and I want 1,000 time points. As far as I know, there is no technology that can draw blood every hour 1,000 times because that's about a month in your life and you wouldn't be sleeping. So, you've got to give me a blood sample every hour, even if that existed. The solution to this problem is a very simple idea. No one can really claim that they invented this because the idea is sort of always been there. If you have ever seen a tree that has been cut cross-sectionally and you see growth rings, each growth ring is roughly 1 year. Right? Hair, and previously I worked on baby teeth, but today we're talking about hair, also grows in this incremental archival manner. So imagine a blood supply going to the follicle and depositing something, and it's like a train. Each train car captures that information for that time and moves ahead, and it's pretty much logged away in that train car. I say pretty much because some things do leak out, some things do leach in, but that's a very, very arcane analysis. Now, this opens up an avenue for us where if you look at the right-hand side for you, and you did a blood test on this individual, this sort of hypothetical blood test, and you saw 2 dots that are roughly close to the x-axis and flat, you would say for this neurotoxic exposure, you haven't experienced much. But what if we collected hair from this individual? And we did. This is real data from a person where we went back 2 years in time, and we see a peak in tin exposure, a neurotoxic element. This person was exposed to one of the California fires, and that's where this happened. And I'm going to come back to this topic of fires and acute periods of exposure, but now we have a technology that can help you go back in time without any missing window. So we're bringing the time dimension into exposome science, because pretty much all of medicine is addicted to these snapshot technologies. For an average person, you go for your wellness check once a year, you get a blood test done, that's a snapshot. Right? You can go to your doctor and ask them, and they'll tell you your cholesterol is high or normal. But if you ask the question, what is the rhythm of my cholesterol? Well, they don't have an answer, right? In fact, I would argue the rhythm of your cholesterol is probably more important than just the level. And that's the question we are trying to answer. Now, trust me, hair is not easy to work with. I used to have hair, and it was amazing. I don't think Dr. Balshaw should laugh, but anyway. You will see some people, and I was one of them, have very curly hair, but when you use lasers, they move in a straight line. So try taking some really curly hair, holding it straight for a long time so the laser can come and analyze it. Good luck. So first challenge is building robotics that are so accurate, they work at a micron scale. Better than Boston Dynamic robots, because they don't work at a micron scale. And making hair straight and literally printing it so that I can analyze it as scale. The next challenge is the outside of hair can be contaminated. So the inside, we open it up like a book, lengthwise, not cross-sectionally, lengthwise, without using heat. We open it up like a book. We take this laser that releases molecules along every growth ring. We measure 100,000 molecular signatures at each growth ring. But let's be honest, there's lots of untargeted metabolomics people there, so I can't fool you. We can only annotate about 10,000 of them to a level where I say, yeah, I kind of know what's there. So we release a huge amount of data, measure it with mass specs, and then we have 4 top-tier AI engineers who actually do pattern recognition at a molecular level, right? And all our biomarkers that we have developed are not concentration-based. They are concentration independent. They are just looking at pattern recognition over time at a molecular level. What does that mean? Imagine a symphony, a molecular symphony. It doesn't matter how high or how softly it's being played, right? So the y-axis doesn't matter, the intensity. It is the rhythmicity. It is the biodynamics. We borrow a lot from this thing called chaos theory, because it actually tells you within chaotic patterns are realms of actual, deterministic regions, and outside that it does become chaotic. And I won't go into too much detail, but chaos is an important aspect of human biology, and I feel it's understudied. Because this is a conference about aging and adult neurological disorders, I'll talk about a pediatric neurodevelopmental disorder. Well, Bob changed the entire title of his talk, so at least I kept the title of my talk, so I'm actually doing pretty well. It's a neurodevelopmental disorder characterized by persistent challenges with social communication and interaction and the presence of restrictive interests or repetitive behaviors. You notice that there is something missing here. Where is the biology in this definition? If your definition of a condition is diagnosed by symptoms, then how do you detect it before it becomes severe enough that symptoms arise? I'm not saying symptomatology, behavior is not important. When I was a clinician, I used to take a detailed behavioral history, but it can't be the beginning, the middle, and the end of the story, right? There has to be some biology. Because of this, these are the challenges facing 200 million plus children globally. There is no biochemical test for autism, right? So we diagnose in the US around 4 to 5 years of age, and we get it wrong very often. The sad reality is in autism, therapy exists and it works, but it works if you find the child early enough. There was a recent trial where they compared 18-month-olds to 27-month-olds, and even in that 9 months, there is a statistically significant improvement in children who got the therapy earlier. There was a trial in the UK which showed that therapy had long-lasting effects even after 6 years, and they just delivered 6 weeks of therapy. So therapy exists. There's not a single FDA-approved drug for autism. So how do we change this? And we have to change it because genomics has tried, and there is no single test. If I do every genomic screen on a newborn baby, I have almost zero predictive power of whether this child is at autism risk, except for some rare syndromes like Fragile X or SHANK3 mutations. Other than those, for the average person, there is no predictability. And it can't be genomics because that's the trend of autism. It keeps increasing in prevalence, and it's just not better diagnosis, it's actually increasing in prevalence. And our genes aren't changing that fast, so it has to be the environment. Put this in the background that pediatric neurology is one of the most rare specialties. We have a huge shortage, and wait lists at certain hospitals in France, in Europe, in the US are over 1 year long. At one state in Children's Hospital of Philadelphia, the wait lists were 2 years long. Imagine calling them up today, June 19th, and then they're saying, come June 20th, 2028, for a diagnosis. Forget when therapy will start. So that's not modern medicine. So I want to take you on a whirlwind journey of how we partially, not completely, partially solve this problem using exposome science, starting off with all those 10,000 molecular signatures and filtering them down to develop what I think is one of the first biochemical markers for autism. I owe a debt of gratitude to my colleague and friend, Shoji Nakayama, who helped us access to his study in Japan, where we had hair from newborn Japanese babies. And again, only robotics can analyze those hair. They're so fine that if you're holding it, sometimes you don't see it. So I'm glad I built these robotics. Twin studies in Sweden with Sven Bolte at the Karolinska Institute, my own hospital at Mount Sinai. We put all of this data together, and we got pretty good feedback from the FDA. The FDA says, this is a breakthrough, you are on the fast track. We got CLIA certification, which is a US-centric, state-by-state approval that you can actually give this to clinics now. You're ready for clinical use. And internationally, we have ISO certification. So a lot of diligence. But that wasn't enough for us. Internally, we decided we want to do a much bigger study and only then go to market. We did a study on another 1,600 families. We also went to a poor community in Mexico. And this is where we have ended up. If you start, and this is the validation set, this is the unseen data set from that 1,600 patient study. So our AI doesn't get to see this. It splits the people at the first analysis into you don't have autism or you do. And there our sensitivity is 96%. And then it takes, and then it puts them into what we call the high risk or non-low risk group. That's what, we are through the regulatory agency, we are allowed to say. And there it splits them into intermediate risk and high risk. For this whole process, the metrics are 96% sensitivity and 90% specificity. So these are pretty solid for a complex neurological disorder. And this is the change I'm trying to bring in the clinics. At present, if you call up a hospital and say, I'm concerned about autism, it's first come, first serve, because they have no accurate triage tool. Now when a patient comes and we say, no, it's very unlikely that you have autism, we are wrong 1 in 900 patients. That's our error rate. 1 in 900 patients do we have a false negative. You can take them off that wait list. I wish someone had taken my daughter off a wait list, and I'll share her story in a minute. If you're intermediate risk, you're only 9% higher, so you're just skirting background risk, you're only slightly higher. But if you're high risk, someone needs to see you now, right? So now we adjust this. You take 10 years of backbreaking science and you compress it to this box, and we actually don't even need the box. The box is just marketing. All we need is the tube in the box because someone needs to clip hair at home. I just need one strand. It's actually very hard to clip one strand, so I say whatever you can grab. In my case, actually, it would be one strand. Then you put it in the tube, ship it to us. No needles, no freezing, no reagents. So there is a whole user experience that's built into this. Time came to roll it out. We made a list of states by resources, and we started at the bottom. So we are rolling out in Mississippi because they have the biggest shortage of autism clinicians. That's a very under-resourced state in the United States. I was invited to meet senior leadership of the administration in DC, and the first question they asked is, how much is this going to cost? This is great. And my proposal to them was, why can't this be a universal screening tool? Almost every baby can give me 1 centimeter of hair by the time they're 1 or 2 months. We already take blood spots. Why don't we do this? They say, run an economic analysis. And when I got it back from an independent consultant, the number in front, there was a negative sign in front of the number. What that means is, if we roll this out, because of early intervention, because of removing the false positives, the wrong diagnoses, we would actually save $1 billion a year. $1 billion in terms of the US budget is nothing, it's just background noise. So essentially, this thing is not going to cost a lot of money if we could roll this out. Now we are rolling this out in Japan at a slow pace, but also in the Middle East, where there's a huge demand. That addresses one path to impact, bringing exposomic biomarkers into precision medicine. But I remember I said, perhaps the fastest path is actually empowering people. And I haven't really discussed that, right? So looking at that, when we were analyzing our hair, we are measuring all this information. And I'm like, we're only using 15 molecular markers for the autism biomarker. What happened to all this other information that we collect? We actually developed a way that you can measure your own environmental exposures, and we present it to people in this very simple report. We give you an overall score, and then we break it down into different elements and different organic exposures, and then we give you action items that you can do from home. And a big part of this idea actually came from parents of autistic children. They're saying, okay, you're delivering us bad news faster and more efficiently and cheaper than the traditional method, but it's still bad news. What do we do with this autism diagnosis? What can we change? If you look at the science, many of the phenotypes related with autism, anxiety, language delays, executive function, are linked to the environmental exposures we study. So now we just create a fancier box with the same tube, because this is a good news product. And we say, here, we can measure all your exposures, and we can actually guide you into taking steps to reduce those exposures and do it yourself. So this story took an interesting turn. There was a massive fire in California in 2025, and many people were told, your houses are now clean. These are the houses that were not burned down. Go back to your home. And many of them said, look, we really don't know what's going on, and it's too late to have a blood test because the fire was a long time back, so we don't know what our background exposure was. Half-life in blood is very short. The New York Times contacted us for an investigative piece. This is a New York Times article. That's me helping a child clip some hair over Zoom. That's a hair being analyzed in my lab that New York Times made a video out of, and we showed that when these families were outside the home, their levels were low. When insurance was paying for them to stay in a hotel, they return home, the exposure goes up. They start cleaning, it sort of comes down, goes up as they release dust, and it gets better. So the insurance companies, when they say this house is clean, they really aren't being completely upfront. The reality is they're doing minimal testing. What happened next is perhaps the highlight of my career, starting with something that individuals asked for, that went to the media and created a real uproar. An assembly member in California introduced this bill, and they directly pointed to our technology and said, based on that article in the New York Times, based on this technology from Mount Sinai, I'm introducing a bill, and the bill says something that would seem logical to all of us. Science gets to decide when a house is safe to return, not an insurance policy, right? Seems obvious, but at present, how many exposures do we measure in a house? Thermostat, fire alarm. But if we were measuring this regularly, then we could happily say, no, I come to the house, my exposure goes up, this house is not clean enough. I'm out of time, so I'll stop there and just jump to this summary. For me personally, it's a mission that we have to be impactful. What I've experienced both as a scientist and as a parent of a child who needed a lot of help and genomics couldn't help her, is that beyond clinical utility, which is very useful, and beyond population level work, we need to empower people to just make their exposome healthier. And I think people are ready to listen to us. Now we have the MAHA movement in the US. Many other countries, we have moved past just being a genomic-centric field of medicine to a field that really embraces a positive environment. I'll just leave this slide up. I'm very grateful to the NIEHS because without some of their funding, none of this would be possible, but I'll stop there. Thank you very much.
Good morning, Carol Dufresne from Bordeaux. I'm here. I'm a bit surprised by the graph you present on the incidence of autism. I have the feeling that from public health researchers and epidemiologists, that there's a clear explanation for that, and that it's not a growth in incidence, and it's only due to better screening program, change in definitions, and also I think a big awareness. So why do you present that as an epidemic or something very worrying?
Yep. Oh, great. Next time I have an autistic patient in front of me, that's what I'll say. But what difference does it make to a patient, right? The answer is, do these people, are they really autistic? The answer is yes. There's many more, and previously we weren't detecting them, but all of these individuals need help. Why didn't we detect this autism before the age of 4 or 5? Because when early intervention would have worked, so that problem still stands. And genomics did not work for any of them, so that problem still stands. So for me, the reason for the increase, we can disagree, but the impact on the families is still the same problem. There's no early detection, there's no good biochemical test, and therefore these children will not be able to thrive to their maximum capacity, right? The rest is an academic argument, and we can have that. Yeah, go ahead.
I don't think it's academic at all. It's a different problem to say that we misdiagnose, and it's a big problem. I think it's not, so we need to improve that than to say that there's a rise in a number of cases.
Okay.
Ismail Nabil from Mount Sinai. Thanks, Manish. I've always listened to you. But one quick question I have in terms of hair, extraction of hair. If we lose our hair, and it's a possibility you're experiencing some of that.
I shave my head. So.
Or shave the head. Do you have options? Other options?
Yeah, so we are working on arm hair. because you'd be surprised after puberty, most people have arm hair. So we're thinking of working on it, but we're not there yet.
So the hair from the head is different from the hair from the chest or the beard or the arm?
Absolutely, yeah.
And they're different exposure.
Yeah. So you will see even children have fine arm hair, but they don't have chest hair and they don't have beards. So we are thinking of arm hair, but we are not there yet. It's just an idea. Okay. But it's a limitation, yes.
And the second question I have is about the work that you have done as far as LA fires.
Yeah.
So the story does follow a person, a family, who basically, he keeps cleaning his house over and over again. And then you saw the levels rise and when he cleans up and then comes down. I know you demonstrated long-term exposure impacts, but what is the short-term exposure impacts like in terms of hair analysis?
So what we do see is that the entire family, when they came back home, the highest period of exposure was when they came back home for everyone. The father shows this pattern of up and down. Now we are analyzing about 200 more families who have approached us from the same fire. So we'll have epidemiologic level data soon. We haven't fully analyzed that. I think I can only answer your question once we have that to know what the global pattern was.
Great talk, very, very innovative technology, bold, new thinking. So a question that I have is, what about time frame? So if you have a centimeter of hair at birth or within a few weeks, what time frame are you actually measuring when you're actually looking at that? Are you getting at some of the earlier developmental exposures?
Yes. At a species level, for everyone, hair grows at about 1 centimeter a month. There are fluctuations, but it's roughly around that. What we are measuring now is not really exposure in the autism case. We are measuring metabolism. So we are saying there's a metabolic disorder. Sure. Using baby teeth, we actually found that the signature exists even in the 3rd trimester. So yes, this pattern is there prenatally, and we see the same pattern in hair and in baby teeth. So we're not really measuring exposure as such. It's more the metabolism of that exposure.
So are you actually looking along the length of a section of hair, and can you measure different parts? Maybe you explained that and I just missed it.
We measure at 1,000 time points, so it's roughly an hourly resolution, roughly. Mm-hmm. And so we develop this temporal profile, and then there's a specific pattern that is an autism pattern. There's another one for ADHD, and then there's the neurotypical pattern.
Thanks.
I think I'm out of time, right? Oh, no, okay, sorry, go ahead.
Manish, amazing work as always, and it's really incredible to watch your transition from teeth to hair. I think that the use cases you provided are compelling and interesting, and I get it. My concern as a physician is this is a nightmare, right? The worst thing that's going to happen to us as physicians is you're going to have these people coming in, they're worried, well, nothing wrong with them. With these results, they're like, what do I do about this? With these toxicants, with very small health effects, the patients people may not even have anything wrong. And I think it's going to be a real challenge to sort of, how you integrate this more broadly into practice or into less defined use cases.
That's a great question. So what we did was we gathered 100 clinicians who sat with us and gave us a lot of information. Right from general pediatricians who said we need a screening tool because we keep referring everyone to specialist centers knowing that there is a 1-year wait list. So we need a rule-out test. So that's why we developed a rule-out test. And we have developmental pediatricians who are in a wide range of response. Some say, look, we don't need it. We have the skills to diagnose. We don't need your tool. That's fine. Others are saying that we need it at critical points. In autism, there are certain critical periods where clinicians are still struggling. Just before regression. What causes a regression event? People don't know. In teenage years, girls who go from pre-puberty into puberty with autism, their symptoms suddenly shift and they can become quite severe. So we are working towards that. Overwhelmingly, the response has been use it as simple as a waitlist management tool, right? To stop me from seeing patients who have nothing doing to be on an autism waitlist. Let's use it as simply as that. So, University of Mississippi is already using us for that purpose. And maybe if the answer is just that, I'm okay with that. More advanced use, we are working with some specialist centers who love this tool and they're using it in a more deep way. But overwhelmingly, the response hasn't been concern. It hasn't been that, what do we do? Because there is a wait list for therapy as well. Instead, the response has been, how do I develop therapy for a 6-month-old? There is therapy for an 18-month-old, But how do I bring that age down for a 6-month-old? So we are working with some researchers on actually developing therapies at a younger age.
Yeah, great talk. My name is Sana Sillier, and I had a more technical question. You mentioned that some chemicals leach out, some get in. And do you pair your tests with, for example, extensive product use questionnaires, because shampoo and all these things, or other things? Because how do you deal with that conundrum?
So a large part of that is sort of avoided, because when we are working with children, for example, there isn't, for young children, there isn't a lot of product use, right? You're not really bleaching, coloring hair for a 7-year-old or using, hair irons and things like that. For older individuals, like we're working on ALS, we have an ALS biomarker. We tell them not to do anything to their hair for a month, and we get a centimeter that's fresh and hasn't experienced all those changes. But yeah, that is a challenge with hair, because people will do a lot to their hair.
And how about leaching, things leaching out?
So it's under extreme, it's exactly what you mentioned. It's under those extreme circumstances. If you're bleaching your hair or something, there is a risk of things leaching out. Nobody has fully figured this out, but we have spoken to experts who work in illicit drug use, because hair is sometimes used for that testing, bulk hair. And they've seen over time that levels fluctuate. Now, is that just metabolism, or is that leaching in and out? There is some concern there, but we don't know for sure. Yeah, okay.